I've got some financial disclosure. Most of them are equipment that is lent by companies, but most of my research is done by public funds from public agencies. My talk will go through an introduction, the methodology we used for the consensus conference, the main recommendations that came out on acute respiratory distress syndrome, and then the conclusion. We were using a definition for acute respiratory distress syndrome that was coming from the American and European consensus conference in 1994, and more recently in Berlin, there was an adaptation of this definition. When we look to the definition and to our practice, there is differences between the adult world and the management of ARDS and what we are facing in pediatrics. The pediatric acute lung disease differs in terms of etiology. So do we need to have specific highlight on this? The pediatric practice differs from adults on the ventilator settings, on the use of blood gases, on some technical aspects. And the outcomes are better for pediatric lung injury. So we conducted a point prevalence study that was presented this morning on the mechanical ventilation strategies, and we showed that there was a high variability among all of us. And the question was, is it possible that we agree on a specific definition and strategy in the management of ARDS? And for that, we discussed with at the PALISI, the Pediatric Acute Lung Injury and Safety Investigators Network, to see how we can go to this to a consensus. Well, first of all, we met with three people: so Neil Thomas from Penn State, Doug Wilson from the University of Virginia, and myself. And when we start discussing on this idea, a few months later, we were looking rather like that, and they finally decided to go through a specific methodology. The main problem is that there is not a lot of evidence in the literature on the definition and management of the ARDS in children. So we had to innovate the methodology for that. We put our ideas in a paper that was been published in Pediatric Critical Care Medicine recently. And then we decided, because there was few data in the literature, low level of evidence on high variability in clinical practice, we decided to use an expert system conference that I was trained with a French-speaking intensive care society that was using such an approach, and then we modified this methodology to adapt it to an international conference. So we designed the methodology. We went to a lot of societies to see if they agreed to support this way of thinking. And here are all the supporters that were involved in our consensus conference. Then we define experts that will work on this consensus conference. And here is the first slide, the first picture we had at the first meeting, and I will go through the methodology just after. So we defined the expert, we defined the topics, we divided ARDS into 9 sections, going through definition, incidence, and epidemiology. And for each subtopics, there was at least 2 experts that were designed to work on that, and you've got the name of the slides. The second topic was physiology, and the third on ventilatory support, the fourth on pulmonary specific ancillary treatment, the fifth on non-pulmonary treatments, the monitoring of patients with pediatric acute lung injury, non-invasive support, and non-invasive ventilation, extracorporeal support for pediatrics, and for morbidity or long-term outcomes. When we came, Doug, Neil, and me, Doug was expecting to have enough recommendations to build a protocol that could be included in research, because he was conducting research in Calfacton and discovered that the different teams were working very differently, so it was difficult to remove the noise due to the different management of the patients. I was expecting to develop a protocolized ventilation strategy in ARDS, and Neil wanted to see how the outcomes could be. So with all this mixed, we went through this organization. The consensus conference was made of 3 meetings, very small town, Chicago, Montreal, and Paris. but most of the work was done between the meetings. And so the methodology is based on Randuncla rating methods. So the 2 or more experts are doing the literature search and are writing recommendations on the arguments for these recommendations. Then we have a meeting with all the recommendations and we discuss them, we arrange the wording to be sure that we can have an agreement on that. And then after, all the experts rate all the recommendations. We do a first rating where we can see agreement, disagreement. The ones who are with a strong agreement, then they are okay. The ones who are with disagreement or equipoise, then we try to reword the recommendations, and then we do a second rating where the experts have a look to the previous quotation that has been done, and then we see if we can have an agreement on these new recommendations that have been rewording. The rating system is a Likert scale from 1 to 9. If the rating is between 7 and 9, then there is an agreement. And we look at the median after removing the highest and lowest grade. So if you have, in our consensus conference, there was 27 experts. So you have 27 people that rate a recommendation, and we remove the lower and the highest rate. So if there is a 9 and a 1, you remove it, you look at the median, and if the median is between 7 and 9, it's an agreement, and if the range, the lower and the highest value after removing one is between 7 and 9, then you got a strong agreement. If the range is outside the 7 and 9, it's a weak agreement. It's very important to understand the process for the agreement we had at the end. So there was a first meeting in Chicago just to present the methodology. Then between Chicago and Montreal, there was a 6-month period of time where all the experts worked on the subtopics, produced recommendations on their subtopics, produced argumentation that we will name the long text recommendation, and then the explication why this recommendation is there. And then we met in Montreal to discuss each recommendations. There was around 150 recommendations that were produced, and it took 2 days to go through that with all the 27 experts discussing it around the table. So that was the meeting in Montreal, and then after that there was the rating system, the first round. Then we came out with 74 recommendations that were with strong agreement, and then we reword the 76 recommendations that were left. There was a back and draw about these recommendations, and then we did a second rating. After the second round, well, we had the third meeting in Paris. We had 7 recommendations that were weak recommendations on the definition. So this was a bit tricky to have a definition, not with a strong agreement. So we rediscussed in Paris with the 7th part of the definition, and then we went out with a strong agreement on the definition. Of course, you can word the things, you can have a strong agreement on something that is saying there is no data in the literature and we should do research on that, and everybody agrees and you've got a strong agreement. So we tried to have a recommendation that were strong enough to help for protocols and strong enough to help for research. So at the end, we came out with 151 recommendations. Only 20 were weak agreement. We did not have any equipoise or disagreement, and this is due to the methodology used. So now, what are the recommendations we've got? There is recommendations that can be used for protocols, and there is one that can be used for research. First of all, as the adults did, we removed the word acute lung injury from the definition, and we kept acute respiratory distress syndrome. So the name that we propose is Pediatric Acute Respiratory Distress Syndrome. As the definition is different from the adults, we will have a definition for pediatric ARDS and then definition for ARDS. Of course, there is the in-between for an adolescent that is admitted in an adult intensive care unit or admitted in a pediatric intensive care. Do we use the pediatric definition or the adult definition? Then we have to choose as an intensivist. But this this can be decided by the intensivist according to either the protocol or for the research that is conducted. The definition included several points that were not addressed by the Berlin definition. We kept to exclude patients with we exclude patients with perinatal related lung disease, but we kept all ages. Timing within 7 days of non-clinical insult, so we keep the same range of time for in this definition. Same also for the origin of edema, respiratory failure not fully explained by cardiac failure or fluid overload. The chest imaging, we changed that because there is many patients with ARDS, when you look at the chest X-ray, there is not a bilateral infiltrate. Within 24 hours, it will probably become bilateral, but you can have severe hypoxemia and only an infiltrate on one side. So we changed the bilateral infiltrate for findings of new infiltrate consistent with acute pulmonary parenchymal disease. For the definition of acute hypoxemia, the definition was based on PaO2 or FiO2 ratio, as you remember, with a number, it would be mild in adult definition if it's below 300. We really believe that we should include ventilatory settings in the definition of acute hypoxemia, and so we use the oxygenation index, and we've we validated this range of oxygenation index for mild, moderate, and severe on databases. I will show you after that. Specifically, Robinder Kemani has got a database in CHL in Los Angeles, in Children's Hospital of Los Angeles, and he showed that there was a correlation of the mortality with the increase of oxygenation index, and this justified the range that are here, with oxygenation index for mild that are between 4 and 8, moderate between 8 and 16, and severe if it's above 16. The other problem, this is on invasive mechanical ventilation. The other problem is that many of the patients have got acute hypoxemia but without an arterial blood gas. So do we include them or not in our management and consider them as ARDS? And the answer among the expert group was yes. And it's why we included in the definition the oxygen saturation index. Oxygen saturation index, the problem is with the curve of oxygen saturation that is flat at the end. So we included that the oxygen saturation index will be used if we do not have an arterial blood gas. And secondly, we need to win the FiO2 to obtain an oxygen saturation of 0.97 or below, as it is validated in the literature. So there is an action to do just to try to keep the oxygen saturation below 97 to be below 98. Start at 97 to be sure to have a criteria to enter this definition. So the range of the oxygen saturation index was defined according to the relationship between PaO2 and SpO2 with a curve. For non-invasive mechanical ventilation, we kept the definition of pediatric ARDS. It was difficult to use the oxygenation index, as the mean airway pressure is not really known. So we kept the PF ratio and SF ratio for that. And so if you are with a full mask, with a bilevel ventilation or only CPAP above 5 centimeters of water, as it is in the adult definition, and you have a PF ratio below 300 or a SF ratio below 264 with a PO2 below 97%, then you have an ARDS. The other point that we raised before starting this consensus conference is that there is several children we have in our PICU that were not in the definition because of their underlying disease. And we tried to go into a definition of ARDS in such patients, and we move forward with this criteria for the definition for cyanotic heart disease, chronic lung disease, and left ventricular dysfunction, but we recognize that it's not very accurate, and probably this will need further work to refine the definition, but it's a start. So we identify that cyanotic heart disease, chronic lung disease, and left ventricular dysfunction cannot go into the definition of the ARDS as it was. And then we said that the standard criteria above for age, timing, origin of edema, and chest imaging with acute deterioration in oxygenation not explained by underlying disease or cardiac disease or the chronic lung disease or left ventricular dysfunction. So that's the definition as we propose to the community. And this definition had a strong agreement. That means that all the experts, eventually but one, but all the experts agreed on that with a median that was between 7 and 9, it was 8. We also wanted to identify children that were at risk of pediatric acute respiratory distress syndrome, because maybe this population should be, we should look at this population and try to avoid any additional factors that may create the more severe disease. And so the definition for the at-risk population is the same on the age, the timing, the origin of edema, the chest imaging, but the criteria for oxygenation was different. If a patient is in invasive mechanical ventilations, if he needs any oxygen supplementations to maintain an SpO2 above 88%, but with an oxygen index below 4 or oxygen saturation index below 5, because otherwise he would have a pediatric ARDS. And in non-invasive mechanical ventilation, any oxygen via mask, nasal cannula, or high-flow cannula. And if it's with oxygen, only oxygen cannula, then it's, the idea was if the FiO2 is above 40%, to attain an oxygen saturation between 88 and 97%. So we tried to go further and define what is 100% of FiO2 with oxygen cannula. That's difficult and a bit tricky. We went back to the physiology of gases and then proposed this definition according to the age. And because there is a minute volume that is behind that, and well, that's the definition as it is, and it may help to define which patient. For example, you've got a patient that is admitted in hemato-oncology, and he has got some oxygen, and they want you for advice, then you can say he's at risk of pediatric ARDS with such a condition. And you will see that a lot of them are in this definition. So that's for the section 1 on the definition. Section 2 was on the pathophysiology and morbidity, and that was rather recommendations on research, and I will just comment one definition. I will not go through all the 150 recommendations, but just on the ones that were the more, to highlight the more important in brackets. So about the ventilatory support, the idea was to define how do we set ventilation when we have patients with a pediatric ARDS that is defined as we've just seen. And here is the 2 recommendations that can come out. We recommend using patient-specific tidal volumes according to disease severity. Tidal volume should be 3 to 6 meters per kilogram ideal body weight. We are not speaking of actual body weight for patients with poor respiratory system compliance and closer to the physiologic range for patients with better preserved respiratory system compliance. We set the ventilation, there was a lot of ideas. Every of us are experts in the domain, and we had difficulties to have a strong agreement. But there was a weak agreement. That means that the median range was between 7 and 9, and some, more than one was outside this range, rate below 7. So in the second recommendation was, in the absence of transpulmonary pressure measurements, we recommend an inspiratory pressure plateau limit of 28 centimeters of water. This is very precise, allowing for slightly higher pressure, plateau pressure, 29 to 32, for patients with increased chest wall compliance. This means reduced chest wall compliance. With increased chest wall elastance, sorry. This means reduced chest wall compliance. For the PEEP setting, what we have shown in studies is that the PEEP we are using is lower than in adults, and we try to put some levels of some numbers. So we recommend moderately elevated levels of PEEPs between 10 and 15 related to the observed oxygenation and hemodynamic response in patients with severe pediatric ARDS, weak agreement. PEEP levels above 15 may be needed for severe ARDS, although attention should be paid to limiting the plateau pressure as previously described in the recommendation I've shown you before. Markers of oxygen delivery, pulmonary compliance, and hemodynamics should be closely monitored as PEEP is increased. That's just logical. About high-frequency oscillatory ventilation, there has been several papers in adults showing that there is no benefit when compared to conventional ventilation. But all the experts around felt that high-frequency oscillation ventilation is part of our panel of treatment in such children. And then the wording is high-frequency oscillatory ventilation should be considered as an alternative mode in hypoxic respiratory failure in patients in whom plateau pressure is above 28 centimeters of water in absence of clinical evidence of reduced chest wall compliance. Such an approach should be considered for those with moderate to severe pediatric ARDS. And about the management of high-frequency oscillatory ventilation, we suggest that the optimal lung volume be achieved by exploration of the potential for lung recruitment by a stepwise increase or decrease of the mean airway pressure under continuous monitoring of the oxygenation and CO2 response as well as hemodynamic parameters. There is other recommendation on high-frequency ventilation, but it's rather on jet ventilation. About gas exchange, still in the ventilatory support, titrate oxygenation and ventilation go based on the perceived risk of the toxicity of the ventilatory support required. That's logical also. For mild pediatric ARDS, meaning PEEP below 10, SpO2 should generally be maintained at 92–97%. And if the third recommendation, after optimizing PEEP, lower SpO2 level in the range of 88–92% should be considered for those with pediatric ARDS with PEEP above 10. We went through the pulmonary specific ancillary treatment, and we had the nitric oxide. We say that it's not recommended, but may be considered. The surfactant, there is not enough data for that. We went through non-pulmonary treatment in pediatric ARDS, sedation or muscular blockade, nutrition, fluid management, transfusion. I will not go through all these recommendations, but there were always strong agreement. And all these recommendations will be published soon in Pediatric Critical Care Medicine. The manuscript is now ready. Monitoring of patients with pediatric ARDS, there is words on the predicted body wave that should be used, and we have work to do to refine how we use the predicted body wave. It can be from AIF length or from ulnar length. About the weaning, we recommend at least daily assessment of predefined clinical and physiological criteria of extubation readiness in order to avoid unnecessary prolonged ventilation. There was a strong agreement across all the experts. And spontaneous breathing trials and or extubation readiness tests should be performed. Non-invasive support was in a pediatric ARDS is not so much demonstrated because there is a risk of deterioration, and so the two recommendations I highlight is that although non-invasive should be delivered in a setting with trained experienced staff and where close monitoring is available to rapidly identify and treat deterioration, and then children using NPPV should be closely monitored for potential problems such as skin breakdown, gastric distension, barotrauma, and conjunctivitis. About ECMO, ECMO is part of our panel also, so we included recommendations, but it's the recommendation we commonly use in the unit with ECMO. And on morbidity and long-term outcomes, we tried to define how the follow-up could be done, and this is one of the recommendations that has been accepted with strong agreement. In all children with pediatric ARDS who undergo invasive mechanical ventilation, we recommend screening for pulmonary function abnormalities within the first year after discharge, including a minimum of respiratory symptom questionnaires on pulse oximetry, and various examples of questionnaires that can be used. So that's the part that it's the problem of knowledge transfer to apply knowledge. So to apply knowledge in a unit, you need to have a protocol that is adapted to your unit, and these kinds of recommendations can be used to build the protocol. That's the idea. There are also recommendations that can be used for research, and I can give you examples. We went through the definitions, and Robinder, as I told you, tested on his database the increase in mortality according to the oxygenation index, and I put you the figure that will be in the manuscript in the supplement of Pediatric Critical Care Medicine. I didn't tell you, but all the long text recommendations with the argument will be on the supplement, and the short text, all the recommendations will be in the normal Pediatric Critical Care Medicine journal. So we tested on other database. Simon did that on his database. Yolanda Lopez on the Spanish database. So there is way to improve or to confirm the definitions that we gave. There is also recommendations for the future. So future studies are needed to determine the optimal common training or effect of automated methodologies to reduce inter-observer variability in the interpretation of chest imaging for pediatric ARDS. And there is a poster that has presented of my team on this topic, and there is 2 papers that will come out on the assessment with a computer-aided diagnosis system for the diagnosis of chest X-ray ARDS. There was also a recommendation on pathophysiology and comorbidities. We recommend development of a validated non-pulmonary organ system failure definition for use in pediatric ARDS research. When we did the third meeting in Paris, there was the team with Francis Leclerc from Lille that has worked on the payload, and then they tested the non-respiratory payload 2 score, and they demonstrated that it's a good predictor of mortality in children with acute respiratory failure, because you need to have a score that excludes the respiratory part. And so the non-respiratory payload 2 was quite good predictors, and it will be published soon. So you see that this recommendation can trigger some research further. We also proposed the endpoints that can be used in trials. So they are all listed in this recommendation that had a strong agreement. I will not go through, but this can help you when you design a research trial on ARDS to know which kind of endpoint you can use. There is a specific recommendation that says that we should not use intermediate endpoints, such as the decrease of the increase of oxygen saturation or whatever, because this is not really clinically relevant, and we rather like to have rates of new or progressive organ dysfunction, of duration of oxygen therapy, or something like that. Here we are. So it was a lot of work. It's 2 years from the idea to the complete consensus conference and recommendations done. Here is I present this on the support of all the members that participated to this consensus conference. And the idea was to bring to the pediatric intensivist community some guidelines that can help into the management inside the unit, but also to the development and research. And then we will see if this work will be useful with time. Thank you very much.